Thank you for watching my video. My name is Ryan and I've created this video as a refresher for ALS and microparamedics in managing patients experiencing distributive shock caused by anaphylaxis. So starting with a quick reminder as to what shock is. Shock is a drop in perfusion creating a mismatch between oxygen demand and oxygen supply. Trying to determine the cause of the shock can be broken down to something wrong with the pump, the pipes, or the fluid. The pump being the heart, the pipes are the arteries, veins, and capillaries, and the fluid is the blood carrying the oxygenated red blood cells to tissues. And as the highlighted picture shows, distributive shock is a problem with the pipes, which is our focus of today's reminder video. Looking into shock and distributive shock specifically, we can easily find definitions, and the general classification comes down to decreased tissue perfusion caused by relative hypovolemia stemming from systemic vasodilation. The decreased blood flow leads to inadequate tissue perfusion to vital organs, and as the etiology shows, one of the most common causes of distributive shock presenting to emergency departments is anaphylaxis. Anaphylaxis falls under the banner of a type 1 hypersensitivity, sometimes referred to as immediate hypersensitivity. A hypersensitivity is when the immune system harms the body instead of protecting the body. There are 4 types of hypersensitivities, with type 1 being IgE antibody mediated. Before we get into the pathophysiology of anaphylaxis, it is important to know that anaphylaxis can be initiated by non-immunological causes, but overwhelmingly the most common presentation that paramedics will see is due to the rapid onset nature of IgE-mediated hypersensitivity. So how does anaphylaxis lead to distributive shock? When learning pathophysiology, I find osmosis education brilliant at breaking down complex topics and have used some snapshots to highlight important parts of the pathophysiology. In the example shown, an individual is first exposed to bee venom from a bee sting. The venom is taken in by dendritic cells to a nearby lymph node and creates an antigen to expose to a T cell. An appropriately matching T cell becomes activated and releases cytokines that causes nearby B cells to create IgE antibodies specific to the bee venom. The antibodies released around the blood are picked up and attaches to the surface of mast cells and basophils. This phase is called the sensitization phase. The immune system's mast cells and basophils are becoming sensitized for future exposures. Now let's say the same individual is stung again by a bee. The same bee venom antigen is present and it binds to IgE antibodies on mast cells around the tissue and basophils circulating around the blood, which cause mast cell and basophil degranulation. This degranulation releases pro-inflammatory molecules. If those same pro-inflammatory molecules are released near the site of exposure only, it would be an allergic response. But when it enters the bloodstream and causes systemic effects, it is an anaphylactic reaction. One of the major pro-inflammatory molecules is histamine. Histamine binds to histamine receptors that can be found in the smooth muscle of the respiratory system and the GI tract. Histamine receptors can also be found within the blood vessel walls. When histamine binds to the receptors within the respiratory system and the gastrointestinal tract, it causes smooth muscle contraction, which leads to bronchospasm and vomiting or diarrhea respectively. When histamine binds to receptors within the vasculature, it leads to vasodilation and increased permeability. The dilated vessels and increased permeability of the vasculature creates the distributive shock that we're discussing. When mast cells and basophils degranulate, they also release pro-inflammatory cytokines. Cytokines released can activate B cells to create further pro-inflammatory response. One of the things released by B cells is leukotrienes that attract neutrophils, mast cells, and basophils that can further degranulate. However, this takes extensive time to activate the B cells and create the leukotrienes to attract the immune cells discussed. This means some patients can have anaphylactic response twice, hours apart from only one exposure to an allergen. This response is called a biphasic reaction. Now, after discussing the pathophysiology of anaphylaxis, it makes the clinical features of anaphylaxis more understandable. When we discuss the histamine release causing smooth muscle contraction within the respiratory system and the gastrointestinal tract, it explains the respiratory and abdominal section within the clinical features. And the vasodilation from histamine leads to the skin and hypotension features. The clinical features are shown within AV-CPGs, which I have added to the slide. AV follows the rash criteria rules of 2 or more organ symptoms mandating treatment, and the extra treatment section attached within the CPGs break down the symptoms for the rash criteria. So R is the respiratory distress, shortness of breath, stridor, or wheeze. A is abdominal issues, meaning abdominal pain, nausea, vomiting, or diarrhea. S are skin issues, so examples would include hives, welts, angioedema. And H is the hypotension seen from vessel dilation. People can also be treated for anaphylaxis if they are suffering from isolated hypotension after exposure from a known antigen, or isolated respiratory distress post known antigen exposure. The table on the bottom right of screen is from Tintinelli's emergency textbook, and it shows the likelihood a patient diagnosed with anaphylaxis experiencing a particular sign or symptom. In the table, I highlighted the clinical features present in 50% or more diagnosed anaphylactic patients. It's important to note that hypotension is only present in approximately a third of diagnosed anaphylaxis patients. This information leads well into the importance of conducting a thorough physical examination. With the physical examination, why the physical examination is important is seen in this slide. Up to 90% of anaphylactic patients will have angioedema or urticaria. While angioedema around the eyes will be an obvious sign, some of the skin symptoms may be hidden under clothing. A patient experiencing urticaria may require exposure to see the symptom. An example may be a patient unconscious for unknown reason may have hypotension, but only removal of clothes will reveal urticaria, which will then shape a paramedic's provisional diagnosis of anaphylaxis. Another reason may be a patient experiencing abdominal pain for an unknown reason, and upon skin exposure reveals skin symptoms as well as the abdominal symptoms. Another sign that may not be visually obvious is the sensation of throat fullness. Thorough questioning of a still conscious patient is important to determine if the patient has certain symptoms that could indicate anaphylaxis. Relevant investigation are questions to ask a patient experiencing anaphylaxis. Patients experiencing anaphylaxis may have had previous anaphylactic episodes, and if they can talk to paramedics, information about previous episodes can help shape management of the patient for best patient outcome. Previous ICU admissions means patients will have a higher probability of refractory anaphylaxis, meaning higher level of care will be required sooner. Remember the basics, like patient medication, because patients experiencing anaphylaxis may be on medications that can affect our management. For example, a patient who takes beta blockers may experience refractory anaphylaxis, and a patient on ACE inhibitors may actually be experiencing ACE inhibitor-induced angioedema. This is a bradykinin-induced angioedema that will be unresponsive to normal anaphylaxis pathway treatment. These type of patients may have a management plan to follow and should be followed. If bradykinin-induced angioedema is suspected and the patient has never experienced this before, or there are no management plans for it, anaphylaxis management should commence. Patients who have anaphylaxis may also have a management plan and should be followed if it is appropriate to do so. Scene leadership is contextual, depending on who you are and where you are. Messages that will be the same for ALS or MICA in both metropolitan and rural setting is when conducting a differential diagnosis for your patient to be suspicious of anaphylaxis and to recognize it early. Early recognition and early management will prevent patient deterioration. Where the leadership messages will differ will be the escalation of care. An anaphylaxis patient can be a complex patient and may require more than one set of hands-on for patient care. Additional paramedics on scene to assist in care and/or driving to hospital can reduce cognitive load and improve patient outcome. This also needs to be weighed against where you are in relation to an appropriate hospital. A Metro ALS unit may be able to get to definitive care quicker than waiting for additional resources to meet at scene or meet en route to hospital. Whereas a rural paramedic may need to escalate resources early and call for HEMS, but also alert a local urgent care facility. The local urgent care facility may be the nearest assistance in some circumstances, and while they may not have the facilities for prolonged care, they can assist in managing the patient until appropriate escalation of care can be organised. Another resource to consider if in a difficult situation is consulting with the clinician. In some circumstances, a patient may require MICA-level interventions, but there are no MICA resources available. A clinician can discuss with you about appropriate additional care options to provide best patient care. This slide is discussing managing the anaphylactic patient and the national and international bodies providing recommendations for how emergency providers should initiate care. The top half of the slide are taken from the World Allergy Organization and the Australian Society of Clinical Immunology and Allergy, better known as ASCIA. The areas circled in green show the primary management of anaphylaxis being intramuscular adrenaline, with both the World Allergy Organization and ASCIA recommending 0.01 milligrams per kilo, which equates to 10 micrograms per kilo, up to a maximum of 0.5 of a milligram intramuscular adrenaline as first-line therapy. The lower half of the slide has a section highlighted which shows how to manage a patient in distributive shock, with the goal being to achieve adequate tissue perfusion utilizing fluid resuscitation and vasopressors. This is because ICU mortality rates increase with increased time with a low mean arterial pressure. Looking at AV's guideline for managing the anaphylactic patient, we can see it can be broken into primary and secondary care. We can see for both adult patients and pediatric patients, intramuscular adrenaline, early escalation care, and oxygen therapy is primary management. MICA paramedics should consider the need for adrenaline infusion if 2 doses of intramuscular adrenaline have been inadequate. Secondary management medications include nebulized adrenaline for upper airway edema, salbutamol, Atrovent, and dexamethasone for treating bronchospasm, normal saline given intravenously to aid perfusion, and glucagon if the patient is refractory to intramuscular adrenaline. At a MICA level, consideration of intubation may be required in extreme circumstances. It would only be if airway edema and respiratory compromise are still present despite interventions. A significant risk-benefit analysis should be considered, understanding that this patient could become a difficult intubation requiring emergency airway interventions, or the process of delayed sequence intubation, which would be required for these patients in respiratory failure, which would prevent pre-oxygenation, which could cause the patient to go into cardiac arrest. Within AV's written guidelines, anaphylaxis management can also be found under the cardiac arrest guideline. Paramedics may need to consider anaphylaxis as a reversible cause for pulseless electrical activity. With this in mind, paramedics should consider normal saline intravenously at 20 mL per kilo. International bodies also say that pregnant anaphylactic patients should be treated as per normal, but placed on their left side to prevent abdominal venous compression. Also to note, as part of management should not be to allow the anaphylactic patient to suddenly stand. Standing can cause empty vena cava syndrome and lead to sudden cardiac arrest. I've broken up pharmacology of anaphylaxis management into primary and secondary management. So, adrenaline is a non-specific adrenergic receptor agonist, meaning it binds to and activates different adrenergic receptor types. When adrenaline binds to the alpha-1 adrenoceptor, it results in increased intracellular calcium, causing smooth muscle contraction. This contraction results in vasoconstriction seen from adrenaline administration. Beta-1 adrenoceptor agonist action causes intracellular cyclic AMP to increase. The rise in cyclic AMP causes increased heart contractility. The beta-2 adrenoceptor agonist action causes increased cyclic AMP, resulting in smooth muscle relaxation, which results in bronchodilation. Adrenaline also prevents further mast cell degranulation by binding to the adrenergic receptors on the mast cell. The use of oxygen is to treat hypoxemia. This can occur due to airway edema, mucosal edema, bronchospasm, or mucus plugging. These can affect ventilation and lead to hypoxemia. Early aggressive application of oxygen improves the fraction of oxygen at the alveolar level, which leads to an increased exchange of oxygen at the cellular level thanks to partial pressure laws and Henry's law. Once hemodynamically stable, oxygen can be titrated as needed. I've included a part of the oxygen guideline where anaphylaxis is included as a critical illness and states patients should receive high flow oxygen to begin with. Please note that during COVID times, managing with high flow oxygen does increase risk of it becoming an aerosol generating procedure. Secondary management within AV guidelines is seen in an ABC order, with a note saying the priority is intramuscular adrenaline. Secondary management is to reduce airway angioedema. Secondary management to reduce airway angioedema is nebulized adrenaline. Activation of the alpha adrenergic receptors within the upper airway causes a rise in intracellular calcium, causing smooth muscle contraction, resulting in vasoconstriction to reduce edema within the upper airway. Breathing management is discussing managing the bronchospasm seen from anaphylaxis. Salbutamol is a beta-2 adrenoceptor agonist. This binds to beta-2 receptors found mainly within the lungs to increase cyclic AMP within the cell. This leads to smooth muscle relaxation and causes bronchodilation. Ipratropium bromide is an anticholinergic medication. It causes bronchodilation by binding to muscarinic receptors and prevents the creation of intracellular cyclic GMP. This reduced cyclic GMP results in smooth muscle relaxation. Dexamethasone is a corticosteroid which suppresses the immune response by preventing the transcription of genes for pro-inflammatory mediators in cells. The suppression of the immune response reduces bronchoconstriction. Circulation management is intravenous normal saline to aid in organ perfusion by increasing preload. This will ultimately increase cardiac output and aid in perfusing oxygenated blood to organs. It also discusses glucagon as a secondary option if the anaphylaxis is refractory to intramuscular adrenaline. Glucagon causes inotropic and chronotropic effects on the heart by increasing intracellular cyclic AMP independently of the adrenergic receptors. When we're at the point of considering transport for the patient, understandably the profoundly unwell patient will require transport, and paramedics are unlikely to have much resistance from patients and loved ones in transporting. But the patient without a management plan who appears well with or without self or paramedic management should still be transported to hospital for observation. The well patient needs to be informed that there is a 20% chance of biphasic reaction and that they should be observed in hospital for 4 hours. This is also supported within the clinical flag section within AV guidelines. Most anaphylactic patients will meet the abnormal vital sign red flags, but under specific conditions, anaphylaxis can be found as a clinical red flag, recommending transport to hospital. If the patient refuses, the clinician should be consulted to ensure the patient is aware of the risks they are accepting. So to sum up, anaphylaxis is one of the leading causes of distributive shock presenting to the emergency department. The management goal within emergency management of distributive shock is to maintain sufficient mean arterial pressure for oxygen and tissue perfusion to prevent cellular hypoxia. When distributive shock is caused by anaphylaxis, adrenaline is the primary management because of the systemic effects of adrenaline counteracting the systemic effects of histamine. And across all levels within the service, early recognition and early intervention is key to positive patient outcome. So that's all I have. I'm going to slowly flick through the reference slides as my outro. I just want to take a second to thank you for watching. Please reach out with feedback. Positive or constructive feedback is welcome, and I hope that this video has been helpful for you. Thank you very much.